Okay. So we will see the abdominal wall. So abdominal wall is limited above by xiphisternum, right and left costal margin, below by the iliac crest and fold of groin, pubic tubercle, pubic crest and pubic symphysis. Now let us see the layers. That is 8 layers from before backwards: skin, superficial fascia, external oblique muscle and its aponeurosis, internal oblique and its aponeurosis, transverse abdominis and the aponeurosis, fascia transversalis, extraperitoneal tissue and parietal peritoneum. But opposite to linea alba, the layers are reduced to 6. And the skin contains Langer's line. Then position of umbilicus is important, that is at the level of L3 and L4. Then in superficial fascia, we have 2 layers, that is superficial fatty layer, that is Camber's fascia, and deep membranous layer, that is called as Scarpa's fascia. And fascia of Camber will continue over the scrotum when it is replaced by Darto's muscle. Now superficial inguinal space is the space between fascia of Scarpa and external oblique aponeurosis, and urine appearing in the space from the superficial perineal pouch. Now there are several linear decusstions in the abdomen. One is the linea alba, then lateral to rectus abdominis you get the linea semilunaris. Then we have the lumbar triangle of Petit bounded by external oblique, latissimus dorsi and the iliac crest. Now external oblique muscle origin, that is by 8 fleshy slabs from the outer surface lower border of lower 8 ribs, and the posterior fibers, they are inserted onto the iliac crest, that is outer lip of ventral segment of iliac crest, and the remaining fibers will passes aponeurosis and it is inserted into linea alba. Now there are modifications, that is lower border of aponeurosis thickened to form the inguinal ligament, that is extending from anterior superior iliac spine to pubic tubercle. Then there is the aponeurosis present also a triangular gap, that is the superficial inguinal ring. And this superficial inguinal ring is seen above and lateral to the pubic crest, and structures passing is ilioinguinal nerve and the spermatic cord or the round ligament. Now this is the inguinal ligament from the anterior superior iliac spine to the pubic tubercle. Now there are modifications, that is called as lacunal ligament or Gibbernard's ligament, forming the medial boundary of femoral ring, that is onto the medial part of pecten pubis. Then we have the pectineal ligament of Cooper, that is extending onto the pecten pubis onto the iliopubic till the iliopubic eminence. Then a reflected part of inguinal ligament is also there. It may be called the third crest of superficial inguinal ring. Then we have the next muscle, internal oblique, that is origin from the lateral 2/3 of upper surface of inguinal ligament, from the intermediate lip of ventral segment of iliac crest, then from the fusion of anterior and middle layer of thoracolumbar fascia, and insertion it forms the roof of the canal, and aponeurosis forms the conjoint tendon. And most posterior fibers are inserted onto the ribs, that is lower 3 to 4 ribs. Then it forms an aponeurosis, and this aponeurosis, on reaching the lateral border of rectus, split into anterior lamellae and posterior lamellae. Now there is a muscle that is formed by the fibers of internal oblique, or it can be joined by the fibers of transverse abdominis. That muscle is cremaster muscle, and it is nerve supply is genitofemoral nerve, that is L1 L2, and action is it pull the testis towards the superficial inguinal ring, and it is responsible for cremastic reflex, then help in thermoregulation of testis. Another transversely running fibers, that is transverse abdominis, from the lateral 1/3 of upper surface of inguinal ligament, from the anterior 2/3 of inner lip of ventral segment of iliac crest, from thoracolumbar fascia, and from the inner surface of lower 6 ribs. And insertion, it forms the conjoint tendon along with the internal oblique, and it is inserted into pubic crest and medial part of pecten pubis, and the remaining fibers end in aponeurosis, forming onto the linea alba. So this linea alba extend from the xiphoid process to the pubic symphysis. Then we have the conjoint tendon formed by the internal oblique and the transversus abdominis muscle. Okay. This is the transverse abdomen internal oblique. So here you have the conjoint tendon. That is, other name is falx inguinalis, and it is inserted onto the pubic crest and the medial part of pecten pubis. It forms the medial half of posterior wall of inguinal canal, and a modification that is called as interfoveolar ligament. Then we have the parietal peritoneum, where you get the median umbilical fold, a pair of medial umbilical fold, a pair of lateral umbilical fold containing inferior epigastric artery. And there are 6 fossae: supravesical, medial inguinal, and lateral inguinal fossae. Now, inguinal triangle of Hasselbalch triangle, or that is a peritoneal triangle bounded laterally by the inferior epigastric artery, medially lateral border of rectus abdominis, and below by the inguinal ligament. And direct hernia enter the canal through this triangle. Now, inguinal canal, it is a musculoaponeurotic tunnel nearly 4 cm, and it extends from the deep inguinal ring to the superficial inguinal ring. You can see external oblique, internal oblique, transverse abdominis, and this is the fascia transversalis. Now, anterior wall is formed by skin, superficial fascia, and the external oblique aponeurosis, and it is partially formed by the fibers of internal oblique. Then, the posterior wall, it is mainly formed by fascia transversalis. It is partially formed by the conjoint tendon and also by the reflected part of inguinal ligament. Roof is formed by arched fibers of internal oblique and transverse abdominis, and floor is formed by the grooved upper surface of inguinal ligament, and medially it is strengthened by the lacunar ligament. And inlet is the deep inguinal ring. Inlet is formed by the deep inguinal ring. Outlet is formed by the superficial inguinal ring. Now we have the hernia. Regarding applied anatomy of inguinal canal, you get the hernia, that is oblique hernia or indirect hernia and direct hernia. Indirect hernia always lies lateral to the inferior epigastric vessels, and it enters the inguinal canal at the deep inguinal ring. And it is more common in males, and usually it is due to the persistence of processus vaginalis. So it is congenital. So types include vaginal, funicular, infantile, and interstitial. Then we have the direct hernia, usually due to the weak abdominal wall seen in elderly, and lies medial to the inferior epigastric vessels, and it rarely enter the scrotum. Then based upon the content, we have the Litter's hernia, that is containing Meckel's diverticulum, Madel's hernia containing 2 loops of bowel. Then there is Pantaloon's hernia, that is direct and indirect hernia on the same side of the groin. Then how to differentiate inguinal and femoral hernia? Inguinal hernia lies above and medial to the pubic tubercle, whereas femoral hernia lies below and lateral to the pubic tubercle. And inguinal is above the crease of the groin, femoral is below the crease of the groin. Inguinal hernia can be reduced completely, femoral cannot be reduced completely. Then cuff impulse is usually present in inguinal hernia, femoral do not have cuff impulse. And strangulation is more common in femoral hernia.